Uh, Thank you so much. I think we have all the presenters for the session. And over to you, Dr. Prateep, to begin the session.
Thank you, Sathyan. Good morning, friends. Welcome you all on behalf of the Scientific Committee AIOS and my co-chair Sathyan. This course is designed basically for the beginners, and we will be teaching them about the perimetry. Sathyan has beautifully designed the course, and he has covered most of the Humphrey and the Octopus, which are the most popular perimeter across the world. We are fortunate enough to have a host of faculties where everyone is a very good teachers. So without wasting a time, let us start the course. And first, I would like to invite Professor Surinder Pandav. He would be talking on how to perform a good perimetry which you can trust. Dr. Pandav is here.
Thank you, Sathyan, and thank you, Prateep. Can you hear me?
Yeah, very much.
And
Yeah, we can hear and see the slides.
as well? Okay, thank you very much for the invitation and to include me into this program. So without wasting time, I'll continue with my topic. So perimetry basically, as you know, is a systematic measurement of the visual field function. And basically we are looking at the limits of the visual field and also the depth or the height of the sensitivity actually. So there's a concept of the field of vision that you're all very familiar with. When you're performing perimetry, it depends on the person who does it. So there is kind of a subjective test there. And therefore, it's very important to take necessary precautions and also understand the process and the procedure for better interpretation. And there are many barriers to the successful visual field testing which we should understand. So there are a number of factors that need to be considered while doing and interpreting visual fields. The test should be relevant to the patient and the diagnosis. The proper strategy must be used. The test conditions should be suitable, and those could be machine related, environment related, or patient related. And finally, if you have done a test, we have to use some tests of reliability to see whether the test is good or not. So regarding the first point, the test must be relevant to the patient or diagnosis. What this means is that the context in which you are doing the visual field is important. So the perimetry should be ordered and interpreted, keeping in mind why the test was done, what is the patient. To give an example, if you have a patient who has a fixation loss, then you might have to, devise a strategy where that has to be compensated for. And also if you're doing for a neurological patient, so you will do a suprathreshold test, which will be most convenient and fast and would give you the same information. So if you have uncooperative children, then you might be, test for FDT. So if you have a BRBO patient and if you're doing tests for BRBO, then you understand what to expect. So if you interpret that test in view of glaucoma, then you will make an error. So the context in which the test is being done, that is important, and that should be known before you subject the patient to the field test. Secondly, to pick the right test. So it's very important to understand what test you want to do. So if you're most of the time from glaucoma point of view, we do standard 24-2 pattern, but you could change it depending on the requirement. So if you want to see a little more subtle defects on the temporal wedge or on the nasal steps, then you might order a 30-2 test. That's if you clinically you feel there should be some visual field defects. If a 24- is turning out with normal or ambiguous, then you could do a 30-2 also. Sometimes the patients cannot perform tests they can't sit on the machine for a longer time. So fast is a good alternative for them. And now we also had 24-2C, which actually means that the 24-2 classically doesn't test points, near the fixation. So here you will test, some more points near the fixation. So if there is a central field defect, which could be missed by 24-2 or 30-2, that can be picked up. So right test should be done. And also we know that what are the limitations of the test that you are doing is basically. So what we need to know is that the perimeter is actually testing certain points at a certain distance, like 6 degrees apart, typically for 24- and 32 tests. So that means there will be a lot of areas in between which are not sampled. So if there is a defect there, that would be missed. So if you want a little more testing to be done, more closer, then you have to go for a 10-2 test or a macular test, especially for the central area. So use the most of the time we use the standard parameters as far as possible. because parameters are all these parameters standardized for different machines depending on whether you are Humphreys or Octopus, some other machines. So there's no need to change these parameters by and large, so that all tests are consistent. They are done with the same standard parameters. So it's very useful to compare them, so you don't have to worry about them. But sometimes you might have to change these tests, so you should know when to change those tests, those parameters, which can be changed manually as well. So if your stimulus size is usually is size 3 Goldman standard is kept, but this is only works if your visual acuity is good. So if your visual acuity is bad, then you might have to change the size to a larger size or increase the illumination. So in that case, all the tests performed subsequently for that patient should be done with the same parameters. So if there is severe visual field loss, you might go for a central 10-2 program rather than 24-2 or 30-2 program. So similarly, you have to, there might be some situations you would like to change the parameters. The other thing is that the test conditions should be monitored and they should be proper. So this could be machine related. That means the calibration should be done properly. So all machines these days actually automated, and you don't have to worry about the calibration, but make sure that the machine is, doing that. And the responsive equipment is very important, like, the peripherals, like you have a mouse or a, button which is not properly maintained, it gets stuck or something, and that could produce, or it doesn't record the response properly. So that can, have influence on the visual field performance. And also use the glass holder and things, the peripheral attachments properly, so that do not create artifacts. And also the seating arrangement has to be comfortable. The room has to be comfortable. It should not be too hot, or cold, or, patient is sweating on the machine. So those parameters need to be controlled. So that means the environment has to be controlled. It should be quiet, optimal lighting, comfortable, and the more important is that the operator has to be understanding, friendly, and should be willing to spend some time to explain what is being done to the patient and reassure the patient about the test if the patient is not performing it better or making some errors. So the test conditions again should be monitored, like if the patient is not well or fatigued, or there are cervical swelling, because there are elderly patients and they might have issues, other issues as well. So that should also be factored in. And finally, we recognize and minimize the artifacts. The patient has ptosis, or patient have very small pupil, or there's a cataract, or corneal opacity, something, or the refractive error which is uncorrected. So all those factors, they can produce artifacts, and they would interfere with the visual field assessments later. So they should be relied. And finally, you look at the reliability parameters. I'm sure they're going to be discussed subsequently also. But you can see there are the fixation errors. So if there are a lot of fixation errors, that would make the field unreliable. So you look at the top corner on the left side of the chart under the 34, the set strategy, you have certain parameters which tell you whether the field is reliable or not. So you have a look at those parameters, and then that will give you the reliability. So if you have too many positive errors, or too many negative errors, or too many fixation losses, then that you have to interpret those results carefully. So by and large, generally speaking, if you have more than 20% losses, all of these parameters are more than 20%, generally speaking, then you have to look at the visual field, whether you want to do, you might like to repeat the test. So to summarize, visual fields are very important for diagnosis of glaucoma patients, and many factors can affect the performance and interpretation. So for proper interpretation of visual field, the context, the strategy, and the patient environment, and many other factors, they should be considered. And also finally, you have some tests of reliability given printed on the chart. They should be within those limits of acceptability. Thank you very much once again for giving me.
Thank you so much, Dr. Pandav, for listing out all the possible influencing factors when you're doing the perimetry. Now we'll just listen to Dr. Manish from Mumbai. We'll listen to him on what are the test strategies that you can do it in the Humphrey's perimetry. Over to you, Manish.
Thank you, and thank you for the invitation and the opportunity to participate in this talk. And you have given me the topic to talk on the strategies which are available in the Humphrey perimeter, and a very specific talk. So I will straight away go into the talk. So basically, you have the strategies, which are two types. You have the standard threshold strategies, and you have That is, the full threshold was the original strategy with which the perimeter first came, and that is a very tedious test in which each and every point is tested right from the lowest threshold, and it is got passed twice, and it is very extensive. Then we had the modification, the CETA, which is the Swedish interactive test algorithm, and you have the CETA standard and the CETA fast. These were designed to cut the testing time without compromising the quality of the visual fields, and they have become the gold standard for us. Especially CETA standard is the most popular threshold strategy which we are using. And now we have come up, as Dr. Pandav mentioned, and I will be coming to that, is the CETA faster, which is come in, and I have used it in some patients and found it to be quite useful, especially in the early glaucoma patients. Now coming to the second areas of the areas which we are going to test. So you have these 10-2, 24-2, 30-2, and 24-2C. These are the test areas. So the 10-2 test area tests only the central 10 degrees around fixation, and it tests 68 points. So it is pretty intensive for the central field. The 24-2 tests 24 degrees field in all directions except nasal, where it is extended up to 30 degrees. The point of doing this is that usually Anderson's criteria and all were applied to 30-2 tests, and they said ignore the edge points. So in the 24-2, edge points are not tested. So you cannot say you have to take into consideration all the points. And in the nasal field, it goes up to include the nasal step area, which is very commonly affected in early glaucoma. The 30-degree field is the 30-2, which tests 74 points. And this was the test which used to be done more popularly. And even now, when you first see a patient, some experts still prefer to do a 30-2 as the first test. The new which has come in is the 24-2C, which is 24 degrees, the 24-2 test plus 10 additional points in the central 10-degree area. And we will be discussing this. So these are the standard layouts. As you can see, to your far extreme right is the 30-2, the standard 30-2 test. In the middle is the 10-2, and that is what I want to make out is 10 degrees only central field, and a pretty intensive 68 points are tested. The 24-2, the most popular test, tests the entire field in 24 degrees, and the nasal area, as you can see, is extending up to 30 degrees. And these kind of changes in the nasal step region are better studied if you test up to 30 degrees over there. So the test algorithms, as we mentioned, the full threshold was the original one. And then subsequently, they came up with the Swedish interactive, which was a smart modification. So what are the differences is that the full threshold, each stimulus is presented at each and every location from the expected normal threshold, and it is adjusted slowly so that you cross the threshold twice. Whereas in CETA test, you have the PDF, that is the probability distribution function, where it is derived from well-known glaucoma eyes, and using a Bayesian mathematical model, it is continuously adjusted during the test. So you have to test less number of stimuli at each point to get the threshold. So that is a smart modification. And in the full threshold, the threshold is determined by stepwise presentation of stimuli across the threshold twice. So it is increased by 2 decibels and then reduced by 1 decibel to cross the threshold twice. Whereas in CETA, it is done by reducing the intensity, and the threshold is crossed only once. So the testing time really comes down with the CETA test. And in the full threshold, additionally, 10 points are tested twice to give you short-term fluctuation. And then it was found that this short-term fluctuation did not add much value to your field interpretation. And therefore, in CETA, there is no point which is tested twice, and you do not get the short-term fluctuation. And last is in the full threshold test, the speed of at which the stimuli are presented is fixed. Whereas in CETA, if the patient responds more rapidly, the speed is increased and the machine adjusts that, and therefore the testing time reduces. Now coming to the very important concept about the central field. There is a lot of studies which have been coming out in the last 5-7 years, which say the central field examination, what we are doing by doing the 24-2 tests, sometimes we are missing the points, and if we are even catching them, like you can see in example A, there are some points in the central field, but if you do the 10- field, you get much more points and you have a better potential of observing this over time. Here we can see that these are the points, and here you are missing some points which are not shown up at all in the 24-2. So it is very important to test central field, and it is not only that, only in advanced glaucoma, even in early glaucoma. So experts were assigned to determine which are the points in the 10-2 field which seem to carry more weightage, and they identified these 10 points which were included in the 24-2. So this is the 10-2 field, the 24-2 field. Overriding it is the 10-2 field, and these are the 10 points which are found to be of extra importance, and they are added to the 10-2 to the 24-2 program to get the 24-2C program. So here you can see these points. These are the central points which are not tested in the traditional 24-2 test. In the 24-2C, these points are tested, and with the newer test algorithm called CETA faster, testing time, as you can see, is really reduced to really small, 2 minutes and 2.5 minutes. And these are patients are really happy with this test strategy, and you are getting so much valuable data of the central field. So you have to decide on what test to do when. For usually first timers, when you are suspecting glaucoma, 30-2 or a 24-2 are generally done. But once the patient has moderate glaucoma, follow-ups are usually done on 24-2. And if it is moderate and advanced and you see involvement in the center, then additionally 10-2 is done. In advanced cases where most of the 24-2 areas are already showing an absolute scotoma, you do a 10-2 because there more valuable information is to be had. So you have an example here of a patient. This is the disc, looks like it is suspicious for glaucoma. So you would like to do a visual field, but you are expecting that this is going to be a more like an inferior defect. So 24-2 tests would suffice in this kind of a scenario. But when you do the test, if you find that there is a defect which is very close to the fixation area, you would prefer to do additionally 10-2, which will give you much more data and show you how close the fixation is threatened, because this will base on how soon the patient runs a risk of losing useful and functional vision. So this is another example where you see the OCT is very, very borderline, but you are having a suspicion that patient has got glaucoma. And you do a 24-2 and see there are no points. But here it is important sometimes to do a central field, and there is increasing importance of doing central fields, even 10-2 fields, even in early glaucoma patients. And therefore, I prefer nowadays to do the 24-2C test with the CETA faster in these kind of early cases. Thank you very much.
Thank you so much, Manish, for being very crisp and almost saying what is that you have to do in which patient. Thank you so much for your excellent talk. Now we will move on to our master, Dr. Prateep Vyas. Let's hear from him on what is that yield of information that you can get from the Humphrey's field test. Over to you, Dr. Prateep.
Thank you, Sathyan. Good morning, everyone. So Manish and Surinder has done most of the job for me. I would be talking on the yield of information from the Humphrey field test. Get lots of information from this test related to glaucoma, related to retina, related to neurological conditions, and you perform the automatic perimetry to detect the pathologies in these three conditions only. So the standard definition of the glaucoma is the glaucomatous optic neuropathy with correlating visual field changes. So it's still the perimetry is the gold standard for diagnosis of glaucoma. That is what is the glaucoma is. Now in glaucoma, what do you do with the perimetry? You assess the defect and you analyze the progression. The quantification of defect and analysis of progression is very essential in glaucoma, because glaucoma is a chronic progressive disease and where the patient loses the vision completely. So when you get the printout of the perimeter, what would you see? First you give an overlook to this, and if you have these kind of fields available with you, I don't get any information out of this. But when you see this, the total deviation plot, the pattern deviation plot, the grayscale, all it's white. And if you look at here, then it's most of the black. And in the center, there is a small seeing area. But if you look at it carefully, you will see that it's a clover leaf defect where the patient has not performed as well. And you can see that there are lots of false negative error. Just now, Venkatesh was asking this question, what about the false negative? So with the false negative, if the patient has scotoma, almost in whole of the field, then obviously they will get. If the patient is not attentive, then yes, you will get this kind of defect. Patient falls asleep during the test. And if on the contrary, if the patient is trigger happy, he keeps on pressing the buzzer while you are performing the test, then you get the white scotoma. Then to get some more information, you can look at the gaze tracking, at how the patient was attentive during the test. And if the gaze tracking is like this, then obviously the patient was not at all attentive, and as well as your technician also was not very attentive, and the patient was continuously moving the eye. While you get very symmetrical pattern of the gaze tracking, that means the patient has performed the test well. Then what kind of a glaucomatous defect you get on the perimetry? So obviously, first you always see the gray scale, but obviously, the gray scale is for not for you. It's basically for the patients and their relative when you want to explain to them. But you would like to see the pattern deviation. It is the most reliable part. And look at here, what you are getting is a classical nasal scale, and here it's a superior arcuate scotoma with the split fixation. Look at here, when the first perimetry was done, there was a generalized reduction in sensitivity, and a couple of years later, totally everything has gone. So why it is so? You have to put your brain, because this was because of the media opacity and the patient has a cataract. You can see over here, the all pattern deviation was clean. Because of the media opacity, there was a generalized reduction in sensitivity. And once you have performed the cataract surgery and you did the perimetry, everything is gone. So when you look at the perimetry, yes, you want a food which is ready to eat, and but still you have to put your brain. So the ready to eat is here, the glaucoma hemifield test, which compares a few points on the superior meridian with the inferior meridian, the mirror images. And based on that, it says that whether the field is normal or it's outside the normal limit or borderline, and there are generalized reduction in sensitivity. So if for the outside normal limit, the P is less than 0.01, which is highly significant. So you get all the ready-made information on the perimetry because the static is there and it's still evolving, so that you can become more and more comfortable. As I said, that the glaucoma is a chronic progressive disease, so you have to do the progression analysis as well. So the first and foremost is important is just look at the overview printout. The overview printout gives most of the information. That even by the gray scale, you can see that yes, the patient is over a period of time has progressed, and the total deviation and pattern deviation plot on the progression analysis. So, but that has become pretty old. And now what we look for is the VFI, is the visual field index. The visual field index is basically the function of the ganglion cells, and the ganglion cells are most densely packed in the central 10 degree. So that's why the more weightage is given to the central area as compared to the peripheral area, and it's a surrogate of the visual function of the patient. So this VFI is very important, and on basis of the VFI, the glaucoma progression analysis has been made. Glaucoma progression analysis is very, very good strategy to tell you about the progression, not only the progression, but the rate of progression as well, where you have to have at least 3 perimetry done. So the first one is the first field, the second one is the second, and this is the last field. And then you get the progression analysis, it's a linear regression plot based on the VFI, and then you can get the predictive value of what this patient would be doing 3 years or 5 years from now, because this patient has rapidly progressed. And obviously, yes, when you do not change the treatment strategy and patient continue to progress with the same rate of progression. So you can see that if this patient would continue to progress with the same speed, in 3 years' time, we will go blind. And on the other hand, you look at this, where this patient is stable for almost 10 years, he has not progressed at all. When you have an advanced glaucoma patient, then what? You can see that it's like a floor effect. So in these Manish is already discussed with you, and you have to perform in this strategy where you cover the 68 point. But here you don't get the GPA and you have to depend on the overview pin down. So there are some other conditions where you are dependent on perimetry, some retinal conditions like the retinitis pigmentosa, where if you want to monitor that how rapidly the retinitis pigmentosa is progressing, you can perform the perimetry test. And then some neurological condition, like you can see that, you know, it's a bitemporal hemianopia. That means the patient has a pituitary lesion. And you can see here that this patient had AIOM, so it was an inferior altitudinal defect, and here it's a quadrant anopia. So in summary, the visual field analysis gives lots of information to us, not only related to glaucoma, but related to retina and the neurological defect as well. And it does a very good progression analysis. And the VFI has added in our armamentarium for the good assessment of the progression of glaucoma and the prediction of glaucoma, that what the patient will do 3 years or 5 years from now. Thank you very much for your patience listening.
Thank you so much, Dr. Prateep, for an excellent talk on what are the informations that you can get it from the Humphrey fields. It is just not enough. You just look at one fields and then say, okay, you have all the data. There are so much that machine can give you. So try to understand this, all the points, so that when you are doing your practice, you can understand what are the other things that you can just look at to assess the progression also in these patients. So now we'll just listen to Dr. Rajul on structure function correlation in Humphreys. Over to you, Rajul. Yeah, we can see your slide. Rajul, just unmute your mic. Rajul, can you unmute your mic? We can see your slide, Rajul. But,
yeah. Now, okay?
Yeah.
Okay. Thanks, Sathyan and AIOC for this talk. So I'll be talking about structure and function assessment and how to correlate
Timer
them.
has to be set at 6. Okay. Thank you.
So I know the first question is there a correlation between the location of optic nerve fiber and the visual field? And I'll be talking about perimetry because that's the machine I have, Humphrey. So there are various publications, and it is well documented that if you look here, the inferior RNFL loss, superior arcuate defect. So there is a correlation between structure and function. The second question is that does structure and function changes occur simultaneously? Now, there is a curvilinear relationship that also is documented. The threshold value on perimetry drops slowly in the early disease, and in the later on, it progresses faster. So it is a curvilinear relation, and there are lots of theory about it. I'm not going to talk about it because we don't have time. The third is that whether the structure function changes detect simultaneously. Again, the answer is no. We have quite a few publications. If you look this patient has definite inferior RNFL loss, the wedge shape defect very clearly visible. His perimetry was normal. On other hand, the definite glaucoma, his patient perimetry showed superior arcuate, which correlated his disc changes, but the OCT was normal. So there are lots of the disc size, there are lots of parameters which plays part in the structure function correlation. We cannot go only by one. We have to correlate both. So if you look the old study, which had only ocular hypertension, and if you look EMGT, which had a definite glaucoma patient, the old study, majority of the patient had optic disc changes on the progression, the first detected, as opposed to EMGT, which had majority of the patient showed progression on the visual field, as opposed to optic disc. And why this difference? So if you look that odds, they had early, no optic changes on the perimetry. In the early stage, the structural changes do happen before visual field. The threshold determination of visual field testing, there's a huge variability. And if the odds shows that nearly 85% on the test retest, the second test, they could not verify the defect which is shown on the first defect. So we must remember that as opposed to EMGT, all the patient had definite visual field defect to start with. And once the visual defect is there, the progression, as I showed in the earlier, that the curvilinear graph, the defect, the damage is picked up faster on the automated perimetry. Then the enders had developed a very sensitive visual field progression criteria, which now we are using on day-to-day practice. So that was another reason of picking up the more defect on the perimetry. The topic was that how best to correlate or how to use in clinical practice. So I thought I'll give few example. Already Manish had talked about the 24 days to see, but if you look the publication, if you look now the data Manish already showed that there are patients where we will have a definite, you can see the inferior thinning is here, but is 24 days 2 is normal. We do 10 days 2 and the points, we pick up the more points. So it is the 10 days 2 is correlating with the structure. So the Humphrey now has a new program 24 days 2C. And why? What is the advantage? The 10 days 2, we do the testing at every 2 decibel as opposed to 6 degree in 24 days 2. So when you combine, you have more points in the central area, which may pick up the glaucoma earlier than 24 days 2. And the 24 days 2, there are 10 points and incorporated in the 24, and they will name this 24 days to see. I'll just give one example. Manish has already described in great detail, so I'm not going to talk in detail, but the normal 24 days to that C is picking up the damage in the central area. So this is the one, and it correlates with the structure. So one way, use 24 days to see, especially in the early stage if the 24/2 is normal. The second, this is not available in a day-to-day practice clinically, but we have a structure function SFF. So what they had done, they had taken another different grip of 48 points. They named it DCF, and they incorporated with the 52 what we have in 24 days 2, and they combined and make it 97 unique test points. The 40 points they had was this. Each zone they had 12 points. The central area they have taken quite a few points, and the data they showed that the structure function SFF test had a much better correlation with the structure. So this is one way. Now we have forum. So how to use forum in clinical practice? The forum, it shows the disc photograph, the perimetry, and OCT and the correlation. Now the materials, they are developing a combined structure function. Like VFI we have, they are developing a combined structure function index, which will estimate the proportion of the loss of RGC compared to the amount of age-related match healthy eye. So they will use the SAP sensitivity and the OCT measurements. This is again not available clinically. Hopefully we'll have in the future. The other way, the forum to use is the structure function correlation in progression, because we know glaucoma is a progressive disease. To correlate in the progression is very important. Sometimes we may have a structure progression, sometimes we have functional progression. So this is one of my patients, which had, you see, this is the GPA, and this is the OCT GPA progression, and the correlation you can see that how it is correlated. This is the macula, this is RNFL, and this is how you use the structure function correlation. Ronnie is going to talk about progression in more detail, so I'll not go in detail. So to conclude, there is a great overlap between the optic nerve head parameter and RNFL in normal and early glaucoma, and because of this overlap, we do not have structure a perfect correlation, and we will never have. There is a large variability in automated perimetry because it's the psychophysical test. So if the patient's mood is not good, he may not do the test properly that day. We know that the current white-to-night perimetry picks up the damage only when there are 20 to 30% ganglion cell loss already has happened. So we need to examine both structure and function, and we can use these 24 days to see the forum to prove the structure function correlation for diagnosis, for progression, and we will have certain newer parameters like the DCF in clinical practice, hopefully in future. So this is the way I would use the structure function together in my clinical practice. Thank you.
Thank you so much, Rajul, for covering up the structure function correlation. We know that one is completely a functional test and other one is a structural test. It's quite difficult. Let's hear from Dr. Angaraj also in the later part how the Octopus correlates. Now we will move on to Dr. Ronnie's presentation on progression. Over to you, Dr. Ronnie.
Thank you, Sathyan.
Give a slide and I can hear your voice. Please go ahead.
Thank you, Sathyan, for the invitation. And so I'm going to try and quickly take you through the visual field progression in Humphrey. And what happens on the for any visual field is that an existing visual field effect can get larger, or it can get deeper with points losing additional sensitivity, or normal areas of the field may get involved. So when you have normal areas of the field getting involved or part of the field getting larger, it's very easy to recognize. And that is where, if you don't have access to any other way of assessing progression, you could just use clinical judgment or the observation of sequential charts. This is far from ideal, but the best, if you are going to do this, the best way of doing this is to use the overview printout on the Humphrey visual perimeter, where you can get an entire series of visual fields printed one after the other. And the advantage of using this technique is that you have all the information that is available on the complete printout for each of these fields provided right there. So you can look at reliability, you can look at the mean deviation, VFI, whatever you want, and you can compare it further down along with the pattern. But the challenge with this type of technique is that while it avoids a variety of algorithms, the challenge is basically, it is difficult for us to deal with the amount of information in the printout. And this is, suppose you start looking at the actual threshold values on the printout, and you can see that at these 3 points, the threshold values have actually reduced. If you're looking at 10 fields, you're not going to be able to follow 58 points on 10 fields to see what has happened to each of these threshold values. And this is more of a problem when you realize that there is a test-retest reliability, which means that every point actually fluctuates. A threshold which is here may be there next time. And as the defects are deeper, this fluctuation is also much more. So it's not possible to actually deal with all this information manually, which is the reason why you need to use progression software such as trend and event analysis. There are 2 basic ways of doing it. One is a trend analysis, where basically what you're doing is you're looking at the mean deviation or the visual field index or the pattern standard deviation over time. So you're looking at that value and you're seeing what happens with time, and then you're applying mathematical regression to it to see whether this is statistically significant or not. And this is usually adjusted for age-related changes. If you have a negative slope or a minus thing, it indicates progression. The problem with this technique is that you can miss localized progression. In order to detect localized progression, that is just a couple of points getting worse, what is done is an event analysis, which is basically you compare the rate of progression on each of these points with this database of standard stable patients. You basically take 2 tests as the baseline, and then you compare thresholds at each point over each additional test and see whether there is a change more than what would be expected in stable glaucoma patients. So what is available to us right now is with the visual field index on the guided progression analysis of the Humphrey. So this is what a printout would look like. You would have the 2 baseline tests there. You would have a VFI plot there and a VFI bar here. And the third section is where you will have the event analysis. And this is what a printout would look like for somebody with progressing disease. So the VFI basically plots the VFI value at each plot, and then it predicts this over a 5-year period. And this is again done by linear regression, and it will give you a value here. Here it is -3 plus minus 0.9 decibels per year, 0.9% per year with 95% confidence intervals. But you need at least 5 exams over a 3-year period of time in order to be accurately predict this. It also gives you the VFI bar, where it tells you that if this patient continues to progress at this rate, this is where his visual field index is going to be after 5 years. In addition to that, on the event analysis, each of these points is classified with an open triangle, a half black triangle, or a completely black triangle, depending on whether that point has deteriorated 1 visit, 2 consecutive visits, or 3 consecutive visits. And when you put this entire information together, this is what you would see. You would see a VFI bar there, and these are the VFI numbers on the side, which is showing how it's getting worse. And you can see on the event analysis too, things are getting worse. But what is typically given is a single printout like this. And here you can see that the VFI is not showing much change over time, neither are the event analysis. Here, both the visual field index, trend, and event analysis. This is also statistically significant. Here also you have multiple points which are getting worse. And this is flagged as possible progression by the machine itself once you have more than 3 points getting worse. And here you have somebody with a stable visual field index. That is, no trend is normal, but you are seeing points on the event analysis which are abnormal. So you need to look at both together, because if you have very localized change, it may not be enough to change the VFI significantly to generate a trend analysis. So you need to look at both this and this in order to take a final decision. So you have a stable VFI with localized progression. So it's important that you rule out other causes of progression too. And other causes, the commonest other cause of progression that you would find is somebody like this, who's had a posterior subcapsular cataract, and you're seeing the visual fields are steadily getting worse. And then you have cataract surgery here and it becomes absolutely normal. So if you have any significant change, such as a cataract surgery, a glaucoma surgery, or let's say laser for diabetic retinopathy, you may need to take a new baseline. So in addition to all these, you should always reconfirm change, meaning any change on a single field is not enough to decide that things have become worse. Always reconfirm change the baseline, even if you do a trabeculectomy, cataract surgery, or JAK caps, and always correlate with other clinical observations before you decide that this progression is because of glaucoma. Thank you.
Yeah, thank you so much, Ronnie. Change is the only constant thing. We know that. And many of us do just look at the single visual fields and then come to a conclusion. And we have two visual fields of the single printouts and say the patient is progressing or not. But it is not just enough. We need to understand the machine gives the software to understand which areas are progressing, which areas are not progressing. So please understand that we have to use all the other software to see the progression. Thank you so much, Ronnie, once again. Now let's move on to Dr. Murali's talk on transitioning to a different perimeter model from Humphrey's to Octopus. Octopus is the other one which has been commonly used. Let's listen to Dr. Murali's talk.
Yeah, thank you, Sathyan and AIOC for this.
Yeah, we can hear and see the slides, Murali. Go on.
Yeah, rather interesting talk. And thank you, Sathyan. Can you hear me now?
Yes, Murali, we can see and hear.
Yeah. So multiple Octopus perimeters have been present over the last, say, 20, 30 years. And all of them have actually evolved from the predecessor of the original perimeter, the Goldman, as you can see in the center. The 123 is in the upper right. Then you have the 300 series, and you have the 900, and you also have the 600. So you have a wide array of models to choose from. The differences between basic perimeters like the ball perimeter, which do the white-on-white perimetry, as well as the direct projection perimeters, are essentially that the ball perimeters can go full field as compared to center field alone with these perimeters, direct projection systems. If you want the refractive correction for distance, you can do it only with the distance correction machine. For this, you need a near correction also. And ambient room light actually becomes very important for the ball type of perimeters. And the 600 is a totally different animal altogether. It does not do white on white. It does a different type of testing. It doesn't have a chin rest, doesn't have a typical Octopus kind of machine. It's a different model altogether. The feature is the pulsar flicker contrast resolution threshold testing. And maybe it picks up glaucoma a little earlier. And you also have the strategies and the targets are quite different. You can see this flicker, which you can see on the screen here. It's quite a different method of testing. The differences between the Humphrey 300 and the Humphrey 700 series would be that the direct projection system of the 300 would have a background illuminance of about 31.5 apostles. The size 3 and size 5 are available, 100 millisecond stimulus duration, 0 decibels would be 4,800 apostles. And of course, these bracketing strategies would be slightly different from the Humphrey's method. So why this table and this elaborate method of telling you the differences is that you can't actually exactly look at the measured sensitivity and compare between perimeters, even between models. For example, if you look at the maximum stimulus in the 900 Octopus, it is 4,000 apostles, whereas it is 10,000 in the Humphrey. So therefore, 1,000 apostles will be 10 decibels on HFA2 as compared to 6 decibels in the Octopus 900. So therefore, straight away 4 decibel offset between the two perimeters. And the test patterns between the perimeters are quite different. I think Manish and others were pointing out about the 24-2 and the lack of the central points which are being tested for decades. We've been having this problem with the Humphrey for the last so many decades, whereas the G program of the Octopus has already solved the problem many, many years ago. And we've been using the G program, which actually tests a lot of points in the center. There's no fixed grid, more important to central points and so on. The program has a different test pattern as compared to the 24-2. And of course, the 24-2C is a new innovation. The macula test patterns are also different with the macula program of the Octopus and the 10-2 of the Humphrey. They're quite different, as you can see the test patterns. And choosing between which test to do for whom, I think Manish pointed out in early glaucomas, advanced glaucomas, when the center field is involved, you have different choice of the strategy and pattern for different perimeters. I'm not getting into that. The sensitivity loss between different devices. For example, you had the Octopus 900, you have the 600, and you have the HFA2. you can't actually compare the normative values of sensitivity between the models, but you can actually compare the sensitivity loss, because it compares with a particular database of normal. The loss can actually be sensitivity loss can actually be compared between devices. And similarly, if you look at the other values, which are called values in the Octopus, these are called thresholds in the Humphrey. The notations are slightly different. In the grayscale, you will actually have the interpolation to decibels in Humphrey, whereas it is percentages in the Octopus. The numerical plots are called total deviation numerical plot. This is called comparison in the Octopus. Slight differences in nomenclature, but the concept is basically the same. And the pattern deviation is corrected comparison. The total deviation is probabilities, and the probability maps are slightly different in terms of appearance and nomenclature, but essentially mean the same thing. But the difference here comes with the pattern standard deviation, which is called the square root of loss variance. And this is a different concept altogether. The MD in mean deviation is called the mean defect in the Octopus, whereas there is no equivalent to the VFI, but the mean defect is a VFI, which you could take as the equivalent of the visual field index. False positives, false negatives in the Humphrey would be measured in percentage, whereas you would actually get a fraction of what was actually tested in the Octopus as a 1/8 and includes the percentage as well. Same with the false negatives, you would get the actual number of tested points and the percentage as well. Fixation loss does not occur because the fixation control in the Octopus perimeters does not allow a stimulus to be presented when fixation loss occurs. A gaze tracker is not available in the Octopus perimeters. The glaucoma hemifield test is an interesting concept similar to the glaucoma hemifield test. The defect curve is equivalent to that. This is the normal in the defect curve. The borderline would mean the entire patient's test results are coming down. This is outside normal limits with a local defect. This is a diffuse defect, and this is a trigger happy patient showing abnormally high sensitivity. This is the equivalent interpretation with the defect curve. Defect curve actually ranks 59 test points from 0 to 1. The least deviated is on the left. The most deviated point is on the right of the curve. And when you're switching machines from Octopus to Octopus 1 model, when you're switching from Humphrey to Octopus, whatever, I have no financial interest. If you're going to switch from Humphrey to the Octopus, which is, in my opinion, a far superior model as far as technology and testing is concerned, if you're doing that, you can actually ensure continuity. And but you must be aware that there can be increased fluctuations in some patients, but not all, with the personal preferences like chin rest and dim lights and so on. Offer a demo test in the new model, and a couple of perimeters need to have a dim ambient room light. And if you look at progression, you can actually import data from the Octopus 123, the earlier model which I had, and the Octopus 300 data can now be incorporated, and you can look at the comparison. Similarly, you can get data from the Humphrey as well and incorporate and compare with the Octopus 900. And like your progression analysis, the GPA trend can be compared to the MD trend. And you also have the GPA event analysis, which is actually equivalent of the cluster trend and the LD trend and the SLB trend, which you can equivalent do. And you also have something called as a polar analysis, which actually looks at structure function correlation, which is not available with the Humphrey perimeter. That's in brief about the differences between the perimeters. I'll stop talking for now.
Thank you so much, Murli. It's not easy for you to cover up the entire.
I know there's so much more to say, but
absolutely, yeah, absolutely true. So I'm sorry for the timing.
No problem at all.
Yeah. So we'll just listen to Dr. Sachin on test strategies. And also we'll hear from him on the yield of information, because Dr. Sood is not available. He's on some emergency. So over to you, Sachin.
Yeah. Is my screen seen?
No. I can hear you well, but we are not able to see the screen.
Okay. So is it seen now?
Still not. Yes. Yes, we can see. We can see and hear you.
I'll just
go ahead, Sachin.
Okay. So I would be covering test strategies when and why in glaucoma for the Octopus perimeter. Now you've heard most of the things which were overlapping from Dr. Murli already. So I will cover those which were not the overlapping things in his lecture. So why is my screen? Screen is not okay. So Octopus, I have the 900 professional model, and that truly compares to the Humphrey because it's a bowl perimeter with the projection type of perimeter. I wouldn't say that 600 is directly comparable, but 900 does compare pretty well. The good point about Octopus is we can customize our test patterns, test strategies, printout formats. We can have custom testing, historical comparison with the Humphrey, and progression for size 3 as well as size 5 tests. So we can have a significant number of permutations that are possible. Now, the test patterns that are available, we have already seen on the Octopus. And for glaucoma, essentially, we use the G pattern and the M pattern because they are the prototype patterns of the Octopus with slight differences from the Humphrey. Although we have the luxury of the 32 pattern from the yesteryears, we have the luxury of 30-2, 24-2, and 10-2 from the Humphrey as well. So if you are comfortable with those patterns, please go ahead with those patterns. We can do tests on those patterns as well. So the G and the M are the basic, and 24-2, 10-2 test patterns, and 30-2 are the add-ons. Except the 24-2C, which is the new addition to Humphrey, all the other test patterns are available. Now, the test strategies. Now, strategies have already been discussed. These strategies are with a slightly different name, but basically convey the same ethos as they are there on the Humphrey. We have the dynamic, which is comparable to the CETA. We have the low vision, which is that option is not there on the Humphrey. We have the top, which is like the CETA fast. We have top faster, which is like the CETA faster, and normal, which is like the normal strategy or the full threshold strategy of the Humphrey. So we have all the strategies available. Testing times are absolutely similar. The foveal thresholding time, although is not there in the Octopus because the fovea is not tested separately as it is done with Humphrey, because we have a central area of the fixation target which is open, unlike the Humphrey, which is a LED diode. And so you have the entire spectrum which you can use in this machine, like G dynamic, G normal, G top, M dynamic, M normal, M top, 24-2 dynamic, 24-2 normal, 24-2 top, same with the 30 degrees, 10 degrees, and M. So M dynamic low vision is a different strategy which is available to the Octopus, not available in the Humphrey. And we can have a 10-2 dynamic low vision size 5 also. So we have all types of permutations and combinations, and normative data is available for all these tests. Now, stimulus size settings, we basically always use the size 3 white on white. As we all know, it is the clinical standard. In the low vision, we have the white on white stimulus size 5, which is used for advanced field loss. Gaze control and fixation targets, we have adjustable. These fixation targets are slightly different from that in the Humphrey, which is a central LED diode or large diamond, small diamond. Here we have 4 LED lights in the central, that is a central target, and then we have a central dot, which is not used for glaucoma testing in the central area. And we have a ring. Ring is used for low vision patients, patients with advanced loss splitting fixation because they can't see the central target well, and patients with central scotomas. Gaze control, we don't have the Heil-Krakow method of blind spot monitoring. Here we have a direct superior video control or a video monitoring and a contact control. The contact loss to the forehead and the chin, the machine freezes. Similarly, if there is motility outside the grid that you can see in the photograph here, if the eyeball moves out of the grid, the machine freezes, there is no stimulus that is introduced. So there is no question of patient, no indirect way of monitoring fixation. It is a direct way. Patient loses fixation, the machine stops. It is commercially called as in 4 levels: none, minimum, medium, and automated eye tracking. In the automated eye tracking, the patient face is again recentered to come in the center of the lens, but we usually do not use that because it is not required. Patients do well with the medium control, that is the blink, dart, and pupil position control, exceedingly well. Now, G pattern is one pattern that we need to talk about, which because it is specific to Octopus. The 24-2C of the Humphrey that has adjusted this to this previous advantage of the Octopus, where you have additional testing points in the central grid or the central 10 to 12 degrees. And apart from that, the difference being that the blind spot has lesser points because usually we do not find significant information just near the blind spot except the bearing. Apart from that, the distance and the area of the pattern is pretty different as compared to that in the 30-2. So the points are around 59 in the G pattern, and they are oriented around the retinal nerve fiber layer alignment. Options that are available for field test area are 74 test location of 30-2 the 30-2, the 32, and the 24-2. So whatever you want to choose, you can choose. If you're not wanting additional data in the center as is available with the G program, you can might as well go ahead being comfortable with the previous 3 programs for which normative data is also available. Now, scotomas in the central part will definitely appear different in the G program because of the denser grid as compared to the 24-2. So the similar patient on the right side on the Humphrey and left side on the Octopus, you can see the data appears slightly different, and you can get a curvilinear scotoma here, whereas it appears like a straight line or 2 points adjacent to each other in the 24-2. So these differences will be there when you transition from one machine to another. Strategy, the dynamic strategy is similar in all respects to the CETA standard strategy. And if you can see here on the right hand side, the examination pattern is given. It is the G, the dynamic, the auto white on white perimetry. Sathyan sir, I'm continuing, right? For the, yeah. So, and here you get all the dimensions like the pupillary, pupillary diameter, the false positive, false negatives, testing time, and the type of fixation monitoring that is used. So all the information that is there, what you see in the Humphrey above is given here, similar fashion, including the pupillary diameter, and the only additional thing is the automated eye tracking, which is slightly different. Now, what you can do here specifically is you can customize the printout. Now, in the printout, if you want here that you want a cluster analysis, you can have one. If you want a corrected cluster, you can have one. If you want a values map, you can have here. So you can just keep on flipping and changing the pattern as you are comfortable in that particular situation. The main difference here is in the total deviation numerical plot. If the deviation is not more than 6 decibels, it is not marked in values but just a plus sign, which decreases the clutter on the map. If there is a complete scotoma or a full scotoma, then it is like a black dot. There is no value which is given. So these are the slight differences in representation which are there and which are very, very convenient to use while testing. Now, if you do a 24-2 test, then also the same kind of printout is available to us, and you can have continuity of the 24-2 test from the previous Humphrey's historical data. And you can see here a beautiful progression map is obtained, and you can have these two last symbols are different, which indicate Octopus machine vis-a-vis the Humphrey machine, which is indicated as a cross, and you can get a progression map even on previous Humphrey data. Now, the M program, which is specific to Octopus, is also slightly different. The targets are oriented just 1 degree apart in the center with a dense central grid and then the radial points. You have 81 test locations vis-a-vis the 76 test locations of the Humphrey, where the central grid is relatively sparse. And again, you have options of using both the programs. So if you have a historical 10-2, you can use a 10-2. If you don't have a historical 10-2, you can start with the M program. The choice is yours. Now, here you can see we've used the size 5 stimulus and a low vision strategy, low vision dynamic strategy in the M program. That is a magnification of the central grid. The test pattern is the same as that of the M program, but the stimulus is size 5. The advantage is it crosses the threshold only once, and it starts with the brightest stimulus. That prevents fatigue from the patient of not seeing the stimulus for a long time, especially in cases of advanced visual loss. Now, the increase in the dynamic range of the machine can be obtained by using the size 5. Now, you can see here the central, the patients having only central vision can be magnified using the M program. Now, you here see a prototype example here, a G dynamic program showing a loss threatening fixation. You make a M dynamic size 3, you can get slightly more information, but when you make a M dynamic size 5, then you get more and more area that you can interpret and follow. On the left side, you have the progression printout of M dynamic size 5, which is usually not available in most machines. Now here again, increasing the dynamic range from a M size 3 to a M size 5, and then following up the size 5 on the progression printout. Because it's a paired t-test, you don't have to have historical data which is acquired over 15 days from a pool of glaucoma stable patients. This just compares the patient to his historical previous data. So the interpretation workflow in Octopus is slightly different. Here we have some similar things like patient detail and the reliability indices, but then you have the defect curve, which is different. The probability map is same as the pattern deviation maps on the Humphrey. We have a grayscale and comparisons, that is the total deviation numerical plot and the grayscale. Grayscale in the Humphrey again is different from the Octopus. In the Humphrey it is absolute. In the Octopus it is relative because it compares it to the normative database. You can have cluster analysis which clusters the points into groups, which the mean of which is denoted in the cluster analysis. You have a polar analysis which detects the structure function correlation. We'll see it in very short in the next few slides. So here we have the maps, the values map. If you want, you can incorporate in the printout. Otherwise, this is the grayscale comparisons, the defect curve, which has already been described. Sir, tell me when the time is up. I'm not able to understand. Is clicking the previous session or the next one?
Yeah, I am sending the message. It is not reading the message. So let him see the message. You please continue.
Okay. So here you have what is called as the defect curve or the Bayes curve. The usage of the curve has already been described by Dr. Murli in his previous slide. And then you can, as I said, you can customize here. In early defects, I customize this to corrected cluster analysis, whereas in the later stage, when the defect becomes more diffuse, I just convert it to cluster analysis so I can get a clear image. And polar analysis will be the field test data result, which is flipped across the horizontal midline. And then you can get each point being represented as a line. The longer the line, the deeper is the defect. So here is the thing that you can see in detail, which I was just talking about. You can customize the grayscale into comparisons and corrected comparisons grayscale, unlike the absolute scale of the Humphrey. Clustering and averaging in the cluster map reduces the influence of normal fluctuation on individual points. 10 clusters are there, and the average of each cluster is denoted. If the value is normal, it is denoted as plus, as is the representation across the octopus perimeter. And if there is a deviation into significant percentile values, and it is denoted in orange and red color with values in bold. So this is the polar analysis. Here the FOV values in the left on these maps, comparisons maps are flipped, and then they are denoted as lines originating from the optic disc, and they will usually compare to the quadrants in which the loss is there. So the longer the lines in the quadrant indicates that particular quadrant is pathological on the optic disc. So you have to see directly the optic disc in that particular way, not flip it anymore, because it has already been flipped while making the polar analysis. As far as the reliability of the global indices go, we have 5 indices with us. We have the MD, the SLV, the DD, the LD, and the MS. The DD and the LD are derived essentially from the defect curve using the 12th to 16th and the 14th to 59th rank of the defect curve, the average of which is given as a diffuse defect or local defect. Insensitivity has already been described. And the glaucoma cluster test is basically the hemifield test principle applied to the glaucoma cluster data. As you know, in hemifield, the nasal, the temporal data, temporal to the optic disc is not being used. Here we use the entire data across the spectrum and then compare. The results are similar to that given on the glaucoma hemifield test. There is a recently added system, that is the Brucini stages in system 2, which divides the field into 6 stages and 3 types using the mean deviation and the pattern standard deviation values. Now, due to paucity of time, I'm not discussing that in detail, but all these can be given as a comprehensive global indices section in the octopus perimeter.
Thank you, Sachin.
Yeah,
thank you so much for covering. In spite of I was just given you a very short notice in the morning. Thank you so much for covering both the talks. Unfortunately, we couldn't get the event today for some emergency.
Thank you. I'll stop sharing.
Move on to structure function correlation, like similar to how the Humphreys was. Over to Dr. Rangaraj.
Dr. Sathyan,
yeah.
How much time should we say?
6 minutes.
6 minutes. Okay, sure.
Yeah, Dr. Rangaraj, we can see your slides.
You can see my slide, right?
And we can hear you as well.
Thank you. So I'll just do a quick, overview of the structure function correlation in octopus data. And Dr. Sachin and most of the other speakers have made it very easy for me. I do have financial. So what I'll do is I'll just do a case-based correlation of the data of how I use it in my clinic, early diagnosis using SAP imaging and overlapping disease when you have cataract and glaucoma, and then how do we manage the follow-up and the challenges and the actual compliance. Now, basically the diagnosis, as you know, we have a structure and function correlation. Now, when you have a software which can also extrapolate the visual function structurally, for example, like Dr. Sachin was saying, when you have something like this, and then it is extrapolated this way, it is so easy to also show it. One moment. It's one moment, please, because this thing is obstructing my slides. Okay, so you can see the correlation very well. So what happens is the polar analysis actually tells you where to see the optic disc when you're in a busy clinic. So I'll just give a couple of examples which will make it more evident. And like I said, the perimetric changes are logarithmic and structural changes are linear. So you'll always have the difference in that. So this is a 47-year-old female, and this is a 7-in-1 printout. Traditionally, we are used to seeing a 7-in-1 printout. Like Dr. Sathyan said, I would always use a 9-in-1 because it also gives me the sector MDs. It's the sector mean defect or mean deviation values. Because when you average an index into a single number, it gets wiped out. But when you go sector-wise, it tells you that one sector is highlighted, and you can also see that there is something happening here. So this patient typically underwent actual clinical examination, and we found there was a small little heme. So next day she came back for a visual field, and sure enough, there was some amount of depression in these areas. So the sensitivities were decreased. So moment you have the sensitivity which is decreased, which is correlating with something like a hemorrhage on the disc, then you know that you are dealing with pathology. So what you do is you go ahead and then analyze it. And when you look at the corrected probabilities, it is showing that 5% of the population, this is normal. So which means it is actually abnormal in 95. So what it tells you is it does not give you the diagnosis, but it tells you that the sensitivity is less. And it's for you to clinically correlate that data. So when you look at the MDs, if you have this reduced to a single number, this will never highlight. So what it does is it gives you this particular area which correlates with the defect which is there. So when you analyze it, you look at this small little bar, and this gray area is the normative area. Then this is 10 decibels, 20, and this is 30. So the length actually tells you what is the depth of the defect, and that correlates very well with the hemorrhage. And when I did a OCT, you must remember that that is not gold standard either. So it just measures a fixed diameter, and that fixed diameter does not coincide, and actually it is green. So I basically have a green disease, and it's a basic, when we look at glaucoma, it's the inner retinal layers which are affected. So the axons have not yet, the Wallerian degeneration has not yet reached the optic nerves. But when you look at the macular map, you can see that definitely there is a loss. And in the left eye, you can see that, it's almost normal. So this is basically a focal defect with green disease. So summarizing this case, I used a 9-in-1 printout, which highlighted what I had to see immediately. So the corrected cluster analysis, the polar analysis displayed the early defect. So isotope representation and fundus picture correlated. And then, of course, the OCT does show a green disease, but then the macular map tells me that there is something going on. So this highlights the need for a good clinical examination along with perimetry, and understand your perimetry very well and where you're deploying it and how you're using it. And this is a second case with overlapping conditions. The 71-year-old male presented defective vision. His IOP was 24. So there is a lot of media haze. Of course, now you have fundus camera like the IDEN, where even if there's a media haze, you can see what's going on. But on careful analysis, there is something going on here. So that this is the left eye and right eye. I like to put the left and right because it's easy to kind of correlate when you're looking at visual fields. And this is the 9-in-1 printout, and you know that something is happening in the nasal fields. And when you look at the polar analysis, which gives you the structural extrapolation, you know that where to look for in the optic disc. And this is called the 2-on-1 printout. So the 2-on-1 printout, and remember, this particular grayscale is derived from the comparisons, meaning that you have the raw values which is indexed to age. So when the raw values are indexed to age, and when you have this, you remove all the unnecessary clutter and you look at the topography of the defect. So when we do a visual field, we are looking at the topography of the defect, and it's not that this many points, this much percentage. We look at what is the topography of the defect. Is that correlating with the structural defect? That's what we're looking at. And this is, of course, the Bebby curve, which tells you that the diffuse defect is here, and you have the focal defects, which are the slope, which is the SLV, which is the same as PSD. And then, of course, across the median graphic, you find that there are some high values across this, which correlate in the actual corrected probability. Corrected probability corrects for age as well as the diffuse defect, and it highlights the focal defects. And this is on the nasal side. So you do have a left to right printout. You can easily, this is where your nose is. So it's very easy for you in a busy clinic not to miss these things. So you have a 9-in-1 printout. You can home on to what you're going to see. And sure enough, you have the actual polar defects and which coincide very well. Now, this is just Photoshop. This is not the way it is there in the software, but this is where it kind of coincides. So AIOC actually extrapolates the functional analysis as a structural representation. And this is, of course, the OCT, which definitely highlights that. We don't need really OCT to tell that, but we can do that with a good clinical examination as well. Okay.
Thank you so much, Dr. Rangaraj.
Thank you.
And in a short notice, again, you could manage to show
Thank you
everything
very
possible.
much.
And I think you have covered my talk as well to an extent. Thank you so much for that as well.
Yes, I will just stop sharing.
Dr. Rangaraj is one of the authors for the Octopus Visual Field Perimetry guidebook. It is one of the wonderful books I think people should read on visual fields. So I'll just move on to my talk on the progression. Assessment of the visual field progression makes sense to understand what is the vision related quality of life for that particular patient. And it is also essential to detect the progression to understand what is the speed of the progression which is going on for the patient, and for us to make some changes in our management strategy. So this is how the Octopus Hack Street, how it gives the software. This can be installed in your desktop, and you can see the right eye, left eye, both eyes. You can see there are multiple graphs you can see. We'll just go through that. So there are various challenges once you are looking at the whether the visual field is progressing or not. The Humphrey, the Octopus gives you the global trend analysis, like what the earlier speakers have shown. And you have the cluster trend analysis, you have the polar trend analysis. These three graphs will give you all the details. So these graphical representations are seen as, once it is stable, it shows the straight line, then worsening, then improving. The lines are there. You can easily interpret that. So this is the slope of a trend analysis, provides the rate of change. So this is called as a trend analysis. And we can say that, okay, you have the slope of 1.9 decibels per year. That means we need to treat this patient much more aggressively than those with when they have the lesser trend or the deviations. So the mean defect trend analysis, this is the interpretation guide. You can see the symbols over there, like how much it is worsening. For example, it is 5% probability or 1% probability. You can see that inverted triangle over there. Then you have the red and green colors. And also you have the floor effect, which has been depicted as black in color. So, and if you have, say, for example, you have multiple visual fields then, and you feel that some of the visual fields are not good enough with the high false positives or false negatives or some of the artifacts, the Octopus, you can really select from your desktop. You can select and just remove those visual fields for the further analysis and understand how the patient is progressing. So this is the typical behavior of a global trend analysis from early to moderate disease, where you have the mean defect, square root of loss variance, diffuse defects, and the local defects. If this shows like this, then we can understand, because we have to take a separate class in detail, but I'm just going to show here as only very small examples here for the time lag. And if the patient is having a cataract, now just I want you to see here, the diffuse defects are increasingly shown here, and you see the local defect also is increasing. So in Octopus, we can separate the diffuse defect graph separately and the local defect, so we can understand whether the patient has a glaucomatous change happening, or is it something else which is showing that as a defect. And if you have a very localized glaucomatous change, just try to see this global trend analysis. You can see that the square root of loss variance, that means there is an increasing in the inhomogeneity of the visual fields. That's why the SLV is high, and you can see the local progression, and the diffuse loss is almost stable. There is not much of a diffuse loss. So as Dr. Rangaraj was mentioning, the cluster trend analysis, and also we have the corrected cluster trend analysis, shows that the similar way that you have one area of the cluster, that is a RNFL, you can see here, and you can just see that where the defect is, if it is closer to the macula, or if it is the central 10 degrees, then you can just make sure that you treat this patient much more aggressively than those without that area is getting affected. So that gives a lot of idea for us whether to treat aggressively or just go as it is. There is no change, fine, we can go as it is. And you can see that in the similar way, you can see the black arrows here that shows that it is a floor effect. You cannot expect anything more to happen. So it just indicates there's nothing more to lose. So once you see that, then you move on to the next strategy. Looking at the polar trend analysis, this shows how much of the loss of the RNFL in that area. And if you have a longer the line, that means more the loss. You have the green color, that means that is improving. Some patients may have that improving signs also. So these are some of the examples you see. This is a stable diffuse pattern, diffuse loss, and you can see that there is improvement in the local defect. And you see this in this, there is an improvement once you've done the cataract surgery that shows an improvement in the diffuse loss. And if there is a glaucoma specific increase, then you can see that local defect is showing the increase in the defect. This Dr. Murli has shown in the previous talk, how you can represent the progression in the visual fields of Humphreys and in the Octopus. So I'm not going to discuss that in much. So very short, thank you so much for your patient attendance. And we'll move on to the next talk from Dr. Prasanna. If you have some time, we'll have the discussion, short discussion. Over to you, Prasanna.
Yes, sir. Am I audible, sir?
You are audible, Prasanna. Your slides are not there.
Yes, sir. I'm sharing, sir.
Yeah. So Prasanna is our fellow. He was there with us earlier. Now he is a consultant at Mahatma Eye Hospital at Trichy. He is going to talk to us on best practices in clinical workflows, especially this is important in the COVID era. So over to you, Prasanna. Yeah, quick talk and...
Sathyan sir, for this wonderful opportunity to talk on the best practice in clinical workflow and how to deliver cost-effective, high-quality patient care. I have no financial disclosure. The structural framework of this talk is related to the visual fields and how we can maximize the use of them with interconnectivity, how we can use it for teleophthalmology, utilization of the patient's wait time to prime them for a visual field examination, attaching the best copy of the visual fields to the patient. And a word of caution among erroneous masks, the lockdown happened, we had to do certain mandatory innovations to actually sustain and bring out the best, especially for visual fields. So we came up with this innovation and we have published this in the recent edition of Indian Journal of Ophthalmology. Make sure you take the cable from the machine to a server or an 8-port switch, whichever is comfortable for you. And from the server, the cable comes back to the laptop. You can see the screen mirror. You have to assign an IP address for it because a web interface is needed, which is mandatory, and an internet connection. Go to control panel, network connections, and you assign an IP address. The steps are also given in our paper as to how to assign an IP address. Once the IP address is assigned, you can just click it in the Google search engine, and then there the display of the visual field is in your PC desktop at your fingertips. So let us see some practical example, a case of progressive primary open-angle glaucoma despite therapy. So the patient's fundus examination is done at our slit lamp in our laptop. The right eye and left eye, you can see a zoomed examination is done. And then enter the MR number of the patient, the visual fields icon is clicked and open. And you can see the same patient's left eye shows previous visits reveal that there's a progression of the superior arcuate scrotum, a case of POAG, which has to be evaluated in terms of mean deviation, square root of loss variance, diffuse defect, and local defect. You can see the curve. So evaluation of this curve in the left eye, and then you can click on the right eye and you can evaluate the right eye. You can keep the right eye and left eye together and check whether there is any asymmetry or symmetry. So all those things can be done, provided there are only previously three visual fields have been done previously. That is what is mandatory. And also, if you want to go for a 2-in-1 graph, you can go for a 2-in-1 graph. If you want to choose a 4-in-1 graph, you can have a 4-in-1. So the displays can be customized. You want to go for a 7-in-1, again, that can be done. The own customized displays, everything can be chosen accordingly. You don't need to keep on taking multiple printouts. And the role of this LAN and telemedicine, as mentioned in one of our papers, make sure you install AnyDesk or TeamViewer in the system that is having this particular LAN or WLAN connection. And then you install the same AnyDesk or the TeamViewer in your personal computer at home. Now it's screen share and screen mirror. You can access all the files remotely. So the structure function correlation assessment can also be done from home. As you can see, the fundus examination being done, the superior notching, the structure has been compared to the polar analysis loss in the functional visual field. And also make sure to use the patient's triage wait time by priming them as to what is expected of them from a visual field. Once upon registration, send if they are a smartphone user, send them what is needed from them. As to priming the patient will save a lot of time for the perimetrist. Step-by-step instructions would really mean a lot for the perimetrist. Attaching the medical records to the patient's phone will serve them wonders because a soft copy cannot be tampered, as you can see on your left, whereas a hard copy can be tampered, can be lost. And this is one of our apps which has been developed courtesy of Dr. Sathyan sir, the eye drop reminder, the hospital-based integrated app only for the registered patients. So there is easy attachments of all the medical data can be done so that the patient has their data fed into them in a soft copy manner. The resuming visual fields testing post COVID-19, the challenges that I practically faced, the problem was with the mask. The patient enters the hospital with a mask correctly positioned, but when the perimetry test was started, the mask was pulled down like this as an innate reflex. What was the problem with that? Yes, there seems to be a problem because they breathe into the bowl type perimeter. The patient may end up contaminating it, and the cleaning part also takes more headache between one patient to the other. It creates a lot of headache as a glaucomatologist for me. And again, if I tell them to overcorrect it, correct it, they tend to overcorrect it. What happens when they overcorrect it? It, as you can see here in the display, it goes up and it causes an artifact, a visual field artifact, an inferior arcuate scotoma kind of glaucomatous mimicking defect happens. So all these can be avoided. We have this new virtual perimetry which is actually having high correlation with the Humphrey perimetry.
I request everyone kindly keep yourself on mute.
Yeah, there's a lot of background noise. Thank you so much, Prasanna, for your wonderful, very short and sweet talk.
Thank you, sir. Thank you.
We'll probably have a few questions because there is only a couple of minutes are left. If any of you want to add any points, all the speakers, would you like to say some points for the audience? Speakers. What is exciting for us is that, of course, we are all hardcore Humphrey users. Some of us have moved to the Octopus just because of the software, which is so excellent. I think somebody is coming. So the Octopus gives a lot of information, especially with the software. You can just see everything in your desktop. So that gives an excellent.
Sorry to interrupt you, sir. Dr. Rajul, kindly keep yourself on mute.
Sure. Yeah. I thought to reset all this.
Yeah.
So once we have this, there is some time. Should I finish my talk? I mean, there is some time now.
Yeah. Yes, Venkatesh. Yes, Venkatesh. Please.
Venkatesh is here.
Rajul, I think you have to switch off your audio. Mute your mic. Venkatesh, unmute your mic.
Unmuted.
Dr. Venkatesh, mute yourself.
He's playing the recorded talk. Sathyan, you're muted.
Prateep, can you just give some comments?
Venkatesh, is he playing his video?
But I'm not able to see actually.
Dr. Sathyan,
just give me a second.
we have only 2 minutes max.
Okay, we'll
just give your inputs if you can about the future perimetry and the virtual reality perimetry. Probably just you can say a few words on your virtual.
Well, I think we'll finish it in 5 minutes so that you can start the next session.
Because we have probably.
Sir, our time limit is already over. We can have max at the most 2 minutes in this session.
Venkatesh?
Okay, you can go for some questions. Okay.
Yeah. No. You just give your inputs on the virtual reality perimetry, the artificial intelligence, which has been used in that. Can you just say a few words?
Yeah, definitely. That's going to be the future, because we are seeing in the pandemic, we are learning a lot of things, like the difficulties in doing an HFA, the contamination part, the mask part. So definitely there's going to be a bigger role for other devices like the virtual reality, iPad based, because home-based management is also going to become a big role in the future. Now, where patients can do their investigations, take their fundus photos, share with the glaucoma specialist for opinion, like how you do a lab test and get your diabetologist opinion. I think these are all going to be future. So we need to explore, we need to experiment, and we are fortunate to experiment some of this. And of course, AI is going to play a very important role, because once you have more and more data, I think the machine has to learn from the data and start helping us in screening and diagnosis, and also in better management. So it can start predicting your results, the long-term results of even surgical success rates, and the prognosis of a patient. So it's going to play a big role, and we have to be open, explore, and also try to experiment some of these new things which are coming up.
Thank you so much, Venkatesh. I'm sorry because there was initial mess up in the timing. I think they got a different set of speakers list, and then we have a different set of speakers list for the organizing committee. So anyway, thank you so much for all the speakers for taking your time out and giving a wonderful talk. And I hope it has been pretty useful for all the attendees for the today's session. Thank you once again, and we'll meet you all.
Sathyan. Bye.
Bye. Thank you.
Thank you.
Thank you so much, Dr. Sathyan, for leading throughout the session. Thank you so much, all the speakers.